بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. My topic today is about the solid renal mass, common causes, less common causes, and the essential information and the key differential diagnosis issues for common and less common causes. Key differential diagnosis issues: solid expansile mass in adult, usually renal cell carcinoma, unless mass contain fat, probably angiomyolipoma. Patient has fever, urosepsis, consider pyelonephritis and renal abscess. Patient is immune compromised, consider lymphoma, post-transplant lymphoproliferative disorder. Patient known to have a primary cancer, consider metastasis. The role of biopsy is evolving, but definitely has role in diagnosis renal lymphoma and metastasis. Useful in diagnosis oncocytoma, angiomyolipoma. Morphology and immunohistochemical features are the key of pathological finding. Routinely performed prior to percutaneous ablation. 20% of small, less than 4 cm enhancing renal mass are benign, non-fat containing angiomyolipoma oncocytoma. Morphology of the lesion also aids the diagnosis. Beans versus spores. Infiltrating tumor maintaining reniform bean shape, consider urothelial carcinoma, collecting duct carcinoma, medullary carcinoma. With circumscribed ball tumor, consider renal cell carcinoma, a clear cell or papillary or chromophobe type. Clinical history is key in diagnosis. Renal trauma, infection, metastasis, lymphoma. Not usually helpful in diagnosis a primary renal tumor. CT or MRI evaluation of renal mass must include non-enhanced and parenchymal phase images. Arterial phase good for diagnosis column of Bertin. Pyrographic phase essential for diagnosis transitional cell carcinoma. The differential diagnosis of solid renal mass include the common diagnosis and include renal cell carcinoma, Wilms tumor, nephroblastoma in children, column of Bertin as a mimicker, and fetal lobulation as a mimicker, and pyelonephritis. The clues for common diagnosis include renal cell carcinoma, usually discovered as incidental finding. The patient may have hematuria or flank pain. Variable appearance and histology, from mostly cystic to hypovascular papillary type to hypervascular most renal cell carcinoma. Large tumor may have lipoid degeneration, invade renal sinus, bury renal fat, simulate angiomyolipoma. Large tumor may also have osseous metastasis. Variable appearance and histology, common renal cell carcinoma subtype, WHO classification, clear cell, papillary, and chromophobe types. Additional rare aggressive renal epithelial tumor may be suggested by central infiltration growth pattern, collecting system, and medullary carcinoma. Large cell carcinoma with the predilection for renal vein inferior vena cava invasion. Here, this is ultrasound patient with mass involving the right mid, above, and mid ball kidney. It is echogenic and patient has uh, hematuria, and in the CT scan not shown in this patient has involving of the renal vein, indicating that the stage 3 renal cell carcinoma confirming with CT and nephrectomy. Here, this is renal cell carcinoma, T1 weighted imaging after contrast involving the right lower ball kidney, incidentally discovered and renal cell carcinoma was confirmed at nephrectomy. Here another patient with a large tumor involving the left kidney, two-third lower ball with invasion of the renal vein and extended to the IVC. Here another patient with renal cell carcinoma, exophytic type. It is the Hansfield unit about 42 and based on single phase. The differential between renal cell and high attenuation cyst cannot be done with only solid phase, and the biopsy performed papillary renal cell carcinoma. Wilms tumor, most common solid renal mass in children, highly variable appearance. And here you see Wilms tumor nephroblastoma with 2 years child with bulbable mass lesion, shows huge enhancing and calcification, replacing most of the kidney and collecting system. Column of Bertin is a mimic curve. It is a hypertrophied column of Bertin of septal cortex that protrudes in the renal sinus, usually between the upper and mid calyxes. Same enhancement characteristic and echogenicity of the renal cortex seen in the ultrasound and CT scan. Utilized Bauer color Doppler to confirm similar vascularity of adjacent cortex if identified at screening ultrasound. And here you see mass lesion indenting the renal sinus as the echogenicity the same as in the cortex, consistent with column of Bertin. Fetal lobulation, persistent cortical lobulation reflecting fetal renal development as multiple separate lobes, enhances like normal cortex and medulla. Pyelonephritis, several focal pyelonephritis, renal abscess or xanthogranulomatous pyelonephritis may be indistinguishable from a tumor by imaging alone. Consider the clinical presentation, needle aspiration, and drainage of the abscess. Here, patient with Pyelonephritis, contrast enhanced CT scan. Patient presented with left renal lesion. Patient has fever, leukocytosis, and nephrectomy confirmed the pyelonephritis. Less common causes include hyperdense renal cyst, mimic angiomyolipoma, renal angiomyolipoma, renal oncocytoma, metastases, and lymphoma, urothelial cell tumor, carcinoma, pyelonephritis, xanthogranulomatosis pyelonephritis, renal trauma, aneurysm, and arteriovenous malformation as a mimicker. Clues for less common causes: hyperdense renal cyst can mimic solid renal mass. High density or hemorrhagic renal cyst is indistinguishable from tumor on either non-enhanced CT or enhanced CT alone. Cyst will not enhance, while viable tumor almost always enhancing more than 20 Hounsfield unit between. Beware papillary renal carcinoma also less enhanced. Sonography useful to show sonolucent content and acoustic enhancement of the hyperdense cyst. Large cyst with extensive hemorrhage may be impossible to distinguish from necrotic tumor. Attenuation of a mass lesion more than 70 Hounsfield on non-contrast enhanced CT scan highly suggestive of hyperdense cyst rather than renal cell carcinoma. Renal angiomyolipoma, most common benign renal solid mass, 95% have identifiable fat on CT or MRI. Use non-contrast enhanced CT scan or MRI to identify small foci of fat. Angiomyolipoma without fat is difficult or impossible to distinguish from renal cell carcinoma by imaging, often hyperdense to kidney or on non-enhanced CT scan. Highly echogenic at ultrasound, though imaging overlap with small echogenic renal cell carcinoma. Features fever, renal cell carcinoma, halo cystic component. Multiple and bilateral seen angiomyolipomas in patients with tuberous sclerosis may result in spontaneous bleeding. Here a patient, right renal cell mass with fat density with solid component consistent with angiomyolipoma. If it is more than 4 cm, it is prone to bleed. Renal Oncocytoma, it is benign epithelial tumor, often has central striate scar and present in about 30 to 50%, though not a specific finding. Segmental inversion pattern suggests, though specificity also disputed. Hypervascular component on corticomedullary phase and nephrographic phase enhancing on corticomedullary phase and nephrographic phase. Hypovascular component on corticomedullary phase retain contrast on nephrographic phase. Here you see renal oncocytoma, axial CT scan, large mass lesion with same attenuation as the kidney, with a central scar here within the mass. and it is characteristic but not specific for renal oncocytoma. Metastases and lymphoma often multiple in patients with non-primary tumor, usually less vascular and less exophytic than renal cell carcinoma. Multiple renal lymphoma pattern multifocal or infiltrating tumor or diffuse bilateral renal enlargement. Consider lymphoma if large tumor and retroperitoneal adenopathy without renal vein invasion. Here you see multiple mass lesion involving both kidneys, more to the right side with multiple sclerosis. And biopsy confirmed B-cell non-Hodgkin lymphoma. Here, this is another patient with angiomyolipoma on the left side and mass lesion on the right side confirmed to be metastasis from lung cancer. Urothelial cell carcinoma, more infiltrative, less expansile than renal cell carcinoma, may be part of multifocal tumor, a bladder more than the kidney, more than the ureter. Mostly low-grade superficial papillary masses, 15% aggressive and invade renal sinus and renal parenchyma. Here you see mass lesion on the involving this patient and filling the right renal pelvis with invasion of the adjacent structures, adjacent renal tissue, and approved to be a transitional cell tumor. And there is a small exophytic mass lesion on the left side and high attenuation approved to be renal cyst. Renal trauma, renal hematoma may be indistinguishable from the renal tumor. History, including possible invasive procedure like biopsy, is the key for differential. Traumatic injury will evolve quickly. Here the patient with renal trauma contrast enhanced CT scan performed 10 days post-trauma with residual clot in the deep interpolar laceration and subacute perinephric hemorrhage. And this it is completely resolved after 6 months and left only scar tissue. Here, this patient with another subcapsular hematoma on the left side after lithotripsy, associated with here there is incidentally discovered splenic artery aneurysm and fatty changes of the liver also noted. Aneurysm and arteriovenous malformation can mimic renal mass lesion. Vascular lesion can mimic tumor or venous carcinoma. Key is multiphasic CT or MRI during rapid bolus of contrast medium or color Doppler ultrasound. Here we see arteriovenous malformation mimicking looks like tumor, and here this is the arteriovenous malformation enhancing mass with patient with hematuria and hypertension. Rare causes but important: renal medullary carcinoma, renal tumor, atypical and rare mesenchymal tumor, juxtaglomerular tumor, plasmacytoma, and small cell carcinoma. The clues for rare causes: renal medullary carcinoma, a rare, highly aggressive tumor and usually associated with sickle cell trait. Renal tumor, atypical and rare, may arise from any mesenchymal component of renal capsule, cortex, or medulla. Generally cannot be diagnosed by imaging. Here there is an infiltrative mass lesion extend into the renal pelvis and IVC. This is highly aggressive tumor, affect young men and associated with sickle cell anemia, and it is medullary renal type of renal cell carcinoma. Alternative differential diagnosis approach: lesion may be hyperdense on non-contrast enhanced CT scan, hyperdense cyst, renal cell carcinoma, oncocytoma, non-fat containing angiomyolipoma, and transitional cell carcinoma. Thank you for watching and listening, hoping to see you in another talk soon.